Hello once again. We are going to continue our talks on the hypertensive disorders of pregnancy, and here we are going to focus on pre-eclampsia, which is a unique disorder to obstetrics. If you haven't already, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can click the link below, or you can click on the I on the upper right-hand corner of your screen. Consider chipping in $1 a month. A little bit goes a long way and helps keep these videos free. Thank you in advance. So we're going to focus on preeclampsia here. There's a few designations of preeclampsia: the mild and the severe, and then there's the preeclampsia that's superimposed on chronic hypertension. Now, in another lecture, I discussed gestational versus chronic hypertension and the difference between the two of them. With one of these forms of preeclampsia, it's superimposed on a patient who's already got hypertension, which preceded the 20-week point at which we can diagnose preeclampsia. So that's a little bit different, but as far as management, it's going to be very similar. So this is how we can kind of conceptualize this. So preeclampsia is always going to be diagnosed after 20 weeks gestation, and it's defined by proteinuria. Now, you may have proteinuria which develops in the context of chronic hypertension, and that would be preeclampsia superimposed on chronic hypertension, or chronic hypertension with superimposed preeclampsia. It's the same thing. They're slightly different diagnoses, but it's the same pathophysiologic process going on. That said, what is this pathophysiologic process? Well, it is I wanted to say a bad word, but it is a cluster F, and it is very, very complicated. We don't really understand it completely. Here's what we do know. It's a disorder of widespread vascular endothelial malfunction and vasospasm. Well, that's very vague, isn't it? And so we don't really know a whole lot about it. There's some competing theories, and if you put the theories together, it doesn't really make a lot of sense that all of them can be true, but they each probably have a little bit of truth. But what we know is that this is a problem with the vessels. At the very least, we know that. And we also know its manifestations. It's clinically defined by hypertension and proteinuria, and that's what separates it from just old garden variety gestational hypertension and chronic hypertension. In preeclampsia, you have to have proteinuria. You have to have more than 300 milligrams of protein coming out the urine every day. And it's got to occur between 20 weeks gestation and 4 to 6 weeks postpartum. So you cannot diagnose preeclampsia until that halfway point in the pregnancy at 20 weeks gestation. So here are the criteria. You need to be beyond 20 weeks gestation. You need to have a blood pressure of 140/90 or greater. And you need to have proteinuria. This can be either a 1+ dipstick protein or a 24-hour urine protein of 300 milligrams. Okay, if you satisfy all three of these, you have preeclampsia. Preeclampsia develops in about 5 to 6% of all live births, although in a substantial number of these, it may not be diagnosed just due to poor prenatal care. Most commonly, preeclampsia is going to be diagnosed towards the end of pregnancy. So we look for it for the first time at 20 weeks gestation, but just because she doesn't have preeclampsia at 20 weeks gestation doesn't mean we stop looking for it, because she may develop it at 32 weeks, or maybe at 34 weeks, at 36 weeks. And she may have preeclampsia then, and then when she is delivering, she develops eclampsia and she has seizures. So that is why we need to continue to keep looking for this. Especially if she's got hypertension, we need to continue looking for this. Every time she comes in, we're going to get a dipstick urine protein, and we're going to keep looking for preeclampsia. No definitive cause has been determined, but it is probably alloimmunogenic in origin, and we can base that based on some of the risk factors. There's probably some kind of immune component to preeclampsia. Okay, and here it is, the risk factors. So the first of these risk factors, and I put these kind of in order of how important I think they are, but other people may disagree. So the first one is nulliparity. But it's not just nulliparity, it's nulliparity with the particular father. So for instance, you have a married couple, and she's getting pregnant for the first time. There's a relatively decent risk to have preeclampsia in that pregnancy. But if she doesn't have preeclampsia in that pregnancy, and then she gets pregnant again by the same man, then her risk is much lower than it was the first time. On the other hand, let's say she gets pregnant by a different man. Her risk of developing preeclampsia would be as if she was getting pregnant for the first time. So there's something about the couple, okay, something about his antigens and her body, that if she doesn't react and get preeclampsia the first time, it's less likely she's going to develop it the second or third time around. But if she has a different partner, that risk goes back up to as if she were nulliparous. Okay, so that's interesting. Extremes of age, that's another big risk factor. So below 20, above 40. Multiple gestation. I put these ones in bold because in the book I read from, these were the ones that were given first. Past medical history. If she's got chronic hypertension, so that's a diagnosis. If she's got chronic hypertension and then she's got preeclampsia superimposed on that, well, if she's got chronic hypertension, she's at risk of getting preeclampsia, and that would be preeclampsia superimposed on chronic hypertension. About 50% of patients with chronic hypertension, possibly even more, go on to develop preeclampsia. If she's got type 1 diabetes, if she's got renal disease, or if she has lupus, what do all of these have in common? These are all small vessel diseases. Okay, so it has something to do with the fact that this is a vascular disease. Preeclampsia is a vascular disease. Family history. This is really interesting, and this kind of goes along the lines of that whole immune thing with the father having something to do with it. If the mother of the father of the baby, so the mother-in-law if they're married, if she had preeclampsia, then this woman is at risk for preeclampsia. So probably some kind of immune thing that the father is carrying, and when he gets her pregnant, he puts her at risk if his mother was affected and sort of passed the risk down to him. So you can see here that it's got to be, it's some kind of interaction between the couple. And then this is another interesting thing. If there are discordance between the ethnicity of the parents, so you have a white mom and a black dad, or a Hispanic dad and an Asian mom, that is a risk factor for preeclampsia. And then African Americans tend to be at higher risk in general compared to other races. Okay? So when you put some of these together, the nulliparity with the particular father, the family history, that interesting thing with the mother-in-law, and then parental ethnic discordance, you're kind of left with the possibility that this is probably something immune in origin. But there are other theories, and so we don't know the exact cause. But these are the risk factors. These are identified risk factors for preeclampsia. What are the complications of preeclampsia? So this can be either on the maternal end or on the fetal end. On the maternal end, she could develop eclampsia. And eclampsia is just preeclampsia where now you're having seizures. Okay, so that is one big complication, and this is bad news. Another thing that could develop is a cerebral hemorrhage. Because this is vascular, because your blood pressure can go up really, really high. I mean, I've heard of cases going above 200 over 120. Very, very high. You can develop a hemorrhage from that. They can also develop coagulation disorders or thrombocytopenia. They can get renal failure because of the vasoconstriction. They can develop hepatic failure because of vasoconstriction to the liver. Essentially, they're getting an ischemia of the liver. And they can get pulmonary edema. And that goes into sort of this pathology of preeclampsia. What's happening is you've got constricted, leaky vessels. And these vessels will cause edema not only into the lungs, but also into the brain, which is why we think seizures develop. It can go into the liver. It can go into all sorts of places. And what's actually going to happen is they're going to have less volume than they would otherwise have in their vascular space. And so when you look at the labs, their hemoglobin may be high because you have hemoconcentration. So they can have this sort of systemic edema. And it used to be one of the criteria for preeclampsia, but it is not anymore, is edema. But you don't have to have edema now to be diagnosed with preeclampsia. That went away a while ago. But edema commonly is a manifestation of preeclampsia, swelling of the legs, for instance, or they may have higher than expected weight gain. Okay, what about on the fetal end? Well, uteroplacental insufficiency or placental infarction because of the vasoconstriction of the placenta. Abruptio placenta. Intrapartum fetal distress. Chronic uteroplacental insufficiency, which will lead to intrauterine growth retardation in a baby that's small for gestational age. Oligohydramnios, because this can not only affect mom's kidneys, but it can affect baby's kidneys too. Baby's kidneys are very sensitive to getting enough blood flow. And then stillbirth, because of the intrapartum fetal distress, the baby can die during delivery. So we distinguish between mild preeclampsia and severe preeclampsia. Mild preeclampsia is just the garden variety preeclampsia, the minimal criteria for diagnosing preeclampsia, meaning that you have a systolic blood pressure of over 140 or a diastolic blood pressure of over 90. And then in addition to the blood pressure manifestations, you need to have a proteinuria. It needs to be either 1+ on the dipstick or 300 milligrams per day on the 24-hour urine protein. That is mild preeclampsia. As long as that's all you've got, you don't have any other symptoms. Now, severe preeclampsia means that you have the symptoms of mild preeclampsia plus a severe feature. And there's a lot of severe features, and you need to have some kind of passing familiarity with them. And so here's what they are. Refractory headache, headache not responding to acetaminophen. Visual changes. It may be anything from blurred vision, double vision, to scotoma, to blindness. Systolic blood pressure over 160 or diastolic blood pressure over 110. Some sources will mislead you and tell you that you have to have a systolic blood pressure over 160 and or a diastolic blood pressure over 110 to have severe preeclampsia. And the fact is you don't. If all you have is visual changes and then you have the 140 or 90 and the proteinuria, it's severe preeclampsia. Okay, so severe preeclampsia does not have a higher threshold for blood pressure. It's the same threshold for blood pressure as mild preeclampsia. But if that blood pressure exceeds 160 systolic or 110 diastolic, then it is severe preeclampsia. So you don't have to have 160 over 110 to be severe, but if you do have 160 over 110 in the presence of proteinuria, then you do have severe preeclampsia. Okay, also pulmonary edema, acute renal failure, oliguria. This all has to do with decreased flow to the kidneys. Large proteinuria, so this is nephrotic range proteinuria. If they have more than 5 grams of protein per day or a 3+ dipstick, then this is severe preeclampsia. Right upper quadrant pain, what does that come from? Well, the right upper quadrant pain actually has to do with either hepatic ischemia or with edema to the Glisson's capsule. And Glisson's capsule is just a capsule that holds the hepatic artery, the portal vein, and the bile ducts. And so either of those can cause right upper quadrant pain. If you have an elevated AST or ALT, likely suggestive of hepatic ischemia. Hemolytic anemia, so you may note this in a variety of ways. They may be jaundiced. They may have an anemia. You may find on your CBC, if you get a smear with it, that they have schistocytes. Okay, so that may be diagnosed in a variety of ways. Thrombocytopenia, why we get a CBC in all these patients with preeclampsia. DIC, how would you note that? Well, you're going to have a low platelet count. You're going to have an elevated PT-PTT. IUGR, you would see on your sono, you should always be getting anatomy scans on all women at 20 weeks. And then if she's diagnosed with preeclampsia, then you should be getting additional sonograms to look for intrauterine growth retardation. And then if there's an abnormal umbilical artery Doppler, remember that's that velocimetry. So then there's this other category, which is chronic hypertension with superimposed preeclampsia. And all this is it's a diagnosis of chronic hypertension, which is where you have hypertension before 20 weeks gestation, and then later on you develop preeclampsia, meaning you have this proteinuria, which develops is present after 20 weeks. Okay, if you have chronic hypertension and then you develop preeclampsia, that's called chronic hypertension with superimposed preeclampsia. Superimposed preeclampsia may also become severe, and the criteria are exactly the same. So if you go over 160 over 110, or you develop visual changes or pulmonary edema or all that stuff, then it's considered chronic hypertension with superimposed severe preeclampsia. So you can see this is really just a nomenclature thing. As I mentioned in the previous lecture on hypertension, a uric acid of more than 5.5 per day can be a good indicator for the presence of preeclampsia in a patient with chronic hypertension. So that can help you. So that's why we get a uric acid level on patients we diagnose chronic hypertension in. So the initial labs you want to get, once you've diagnosed a patient with preeclampsia, the first thing you want to do is get this set of labs. So you want to get a CBC with smear. You want to get a BMP, which is going to include your BUN creatinine levels. You want to get liver function tests. You want to get uric acid levels. That's going to help with assessing renal function. You want to get a PT-PTT, and you want to get fibrinogen. Okay, so why do we get a CBC? Well, you want to get a CBC with smear because that's going to help you look for the possibility of hemolytic anemia. It's also going to help you look for low platelets. It's also going to help you assess the degree of hemoconcentration, which tells you how much fluid she's losing as far as edema goes. So low platelets shows you the possibility of thrombocytopenia, which is a criteria for severe preeclampsia, as well as the HELP syndrome, which is a very specific category of severe preeclampsia. It can also tell you if there's DIC going on, another manifestation of the severe preeclampsia. If she's got DIC, she's got severe preeclampsia. Also, normocytic anemia and schistocytes. Normocytic anemia you'd see on CBC. Schistocytes you would see on smear. That points to a hemolytic anemia, which is another of the criteria for HELP syndrome. HELP syndrome, in case you forgot, is hemolytic anemia, H, elevated liver enzymes, EL, and low platelets, LP. Okay, the BMP, what does that tell us? Well, when we look at the BUN creatinine level, if that's disturbed, it points to renal dysfunction. And acute renal failure is a criteria for, if you have that, it's severe preeclampsia. Liver function tests, elevated liver enzymes. That is a criteria for severe preeclampsia. It also is a criteria for HELP syndrome. Uric acid level, if it's elevated, it points towards renal dysfunction. PT-PTT, why do we get that? Simple, because if it's elevated, it points towards DIC. You would also see low platelets in DIC. And then fibrinogen, this is probably the least important out of all of these, but if that's decreased, that points towards DIC. Okay, so you can see the common thread of all these labs is to look for some of the things that points us towards a severe preeclampsia rather than just old mild preeclampsia. Because we don't want to wait until the woman is symptomatic of severe preeclampsia. Because if she has one of these things, let's say she has a hemolytic anemia, she's at a very, very high risk to ultimately develop visual changes or seizures. And so we need to be very, very careful and get these labs so we can determine if she already has severe preeclampsia so that we are monitoring her much more closely than if these were all normal. She would have just mild preeclampsia and her prognosis is a little bit better. Okay, so that's why we get these labs. You may want to consider amniocentesis for a patient with preeclampsia to assess fetal lung maturity, and this can be done at whatever point you feel is necessary. But typically, this is often done around 26 to 28 weeks when we know that the fetus is now viable, because if you do it at 20 weeks, it really doesn't make any sense, because if she needs to be delivered at that point, the baby's not going to survive. So you may do it at 26, 28 weeks. It's commonly done around 32 weeks, because 32 weeks is sort of the beginning point when the fetal lungs begin to really mature. And so you get the amniocentesis and you get that, remember, that lecithin sphingomyelin ratio. And if that ratio is above 2.4, then that tells you that the fetal lungs are developed. So an amniocentesis may be done at some point to assess fetal lung maturity. So I just thought I'd throw that in there. Okay, the management for preeclampsia. The only way you can really cure preeclampsia is to deliver the infant. As long as that infant's in there, mom is always going to have preeclampsia. Now, the management is going to differ depending on whether she has mild preeclampsia or severe preeclampsia. Again, big reason why it's good to get those labs. So if she has mild preeclampsia, the question is now, is she stable? If she's not stable, you need to induce labor. Okay, if she's not stable, you need to induce labor, and you need to give her betamethasone if she's not term yet. Okay, so if she's before, if really it's 30, I would say 34 weeks, you're probably pretty good not giving her betamethasone. But really anything before that, you really don't know if the lungs are matured yet. If you have time to do an amniocentesis, which you probably don't, you can assess fetal lung maturity. But if she is, I would say, for test purposes, anything before 34 weeks, you should give her betamethasone to make sure that those fetal lungs are matured. So you want to give her betamethasone and induce her if she's unstable. Okay, and by unstable, I mean any signs of renal failure, pulmonary edema, hepatic injury, HELP, or DIC. You want to get that baby out of her. You may give her seizure prophylaxis with mild preeclampsia, and if you do, you give magnesium sulfate. Now, on the other hand, if she's stable and she's preterm, you do expectant management. You're going to give her betamethasone because if for some reason she becomes unstable, you want those fetal lungs matured. Okay, so the only time we're going to induce her with mild preeclampsia is if she's term, meaning it's good to deliver the baby will be fine, or if she's unstable, meaning we need to deliver the baby because mom is not doing well. Otherwise, we wait. Okay, and with mild preeclampsia, seizure prophylaxis with magnesium sulfate is optional. Now, with severe preeclampsia, we're in a little bit more problematic situation where we need to be a little bit more aggressive. So if she's 24 to 32 weeks and she's stable, we don't want to induce her. We want to wait as long as we can because the baby is still developing. So we do expectant management, we admit her to the hospital, and we give her betamethasone because if something goes wrong, and it very well might because she has severe preeclampsia, we want that baby's lungs to be developed and matured. So we admit her to the hospital and give her betamethasone so that when that baby comes out, the lungs are properly developed. Because remember, what happens if the lungs aren't developed, you can get neonatal respiratory distress syndrome because you don't have surfactant. So you need to give betamethasone. Now, if she's after 32 weeks with severe preeclampsia, then you are going to deliver her. Or if she's unstable, just like for mild preeclampsia, if she's unstable, then you deliver her. Okay, so you'll induce labor, and you can induce labor by giving prostaglandins, Pitocin, you can do artificial rupture of membranes, whatever you need to do to induce labor. And then you'll attempt vaginal delivery. You don't need to go straight into C-section. You just, you can try to deliver vaginally. C-section, just your normal obstetric indications for C-section. Now, with severe preeclampsia, you must give magnesium sulfate, seizure prophylaxis, because severe preeclampsia, those patients are at significant risk to become full-blown eclamptic. So we give seizure prophylaxis with magnesium sulfate. You're going to give, I believe it's 4 grams bolus, and then 2 grams per hour after that. Don't quote me on that. I'm not good at memorizing dosages. Blood pressure control, we need to do that as well because typically patients with severe preeclampsia are going to, if they're not already running 160 over 110, they may very well go up that high during delivery because delivery typically causes your blood pressure to go up. You'll need to give them hydralazine and or labetalol, and that will be given IV. Okay, so we do induction of labor, seizure prophylaxis, and blood pressure control if she's more than 32 weeks. 32 weeks, we typically assume that the lungs are developed. Okay, 24 to 32 weeks, the lungs aren't developed, so we need to give betamethasone. Now, when I say 24 to 32 weeks, expectant management and betamethasone, that's assuming that she's stable. If she's unstable, it's automatic delivery. If she's more than 32 weeks, baby is probably going to be just fine, automatic delivery. The only time we will watch and wait with severe preeclampsia is if she's less than 32 weeks and she's stable. At that point, we can kind of take a little bit of a gamble for the baby's sake. But if she's more than 32 weeks, we can pretty much assume that the baby is going to be okay, the lungs are going to be developed. Or if she's unstable, we're pretty much between a rock and a hard place. We need to get that baby out. Okay? So hopefully that makes sense. The only time we do expectant management is when we are going to take a little bit of a risk for mom because we want to get that baby a little bit more developed. Okay, but she has to be stable to do that. We're not going to risk mom's life for the baby. That's just the way we do things. Okay, so as I said, unstable are signs of renal failure, pulmonary edema, hepatic injury, HELLP syndrome, and DIC. So following up after mom delivers, you want to continue the magnesium sulfate for 12 to 24 hours postpartum. And the reason for that is because 25% of seizures occur in the postpartum period. So she's not out of the woods after that baby's out. There's still going to be some edema, right? And we have kind of ascertained that the seizures, the big risk of the seizures is from the edema in the brain. 25% occur in the postpartum period. As a matter of fact, 50% of seizures, and this would be eclamptic seizures, occur intrapartum, so while she's trying to deliver. That's a bad, bad, bad deal because the baby can become very compromised in that situation. I do want to bring up, though, real quick, that if she does have a seizure, and we'll talk about this when we talk about eclampsia, but if she does have a seizure, we are not giving anti-epileptic drugs. You're not giving phenobarbital. Magnesium sulfate is actually the best drug to give a eclamptic seizure patient. Okay. You want to monitor her blood pressure. Her blood pressure is going to be labile for typically the next 6 months after she delivers. So you may treat that short term with labetalol, nifedipine, or hydralazine. Take your pick. You want to repeat the CBC, BUN, creatinine, and liver function tests for 3 days because she may actually develop HELLP syndrome after. She may not have had HELLP syndrome all the way until delivery, and then she may develop HELLP syndrome the day after she gives birth. So you want to keep an eye out for that because it's not uncommon for HELLP syndrome to develop after delivery. So we're looking for platelets, we're looking for renal function, we're looking for liver enzymes. And then patient education. Make sure she's aware that it's got a 10 to 33% recurrence rate. Typically it's higher if the preeclampsia was more severe, lower if it was less severe. If this was superimposed preeclampsia, meaning you had chronic hypertension and preeclampsia superimposed on that, it's actually a 70% recurrence rate. Remember that if you have chronic hypertension, your risk of developing preeclampsia is already 50%. So it's going to be higher if you already have developed preeclampsia with your chronic hypertension. And then this is interesting. If this is something to tell her, if you take a low-dose aspirin daily prior to getting pregnant again, and then you continue taking that aspirin during your next pregnancy, it actually reduces your risk of developing preeclampsia and the complications that stem from preeclampsia. And the reason they think is because of the molecular basis for preeclampsia, where there's an imbalance between thromboxanes and prostacyclins. And so what we're doing with aspirin is we're inhibiting that. And so we're kind of preventing preeclampsia at the molecular level. It doesn't always work, but it reduces your risk rather substantially, actually. Okay, and so that's all I've got for you for preeclampsia.